Thank you, Dr. Partha, for inviting me to this course, and good morning, dear friends. I'll be showing you some of the cases, challenging cases in phakic IOLs. Going on to the first case. I am a consultant to Carl Zeiss Meditech. This was a 21-year-old female. You can see the -9 with 0.5 cylinder, -9.25, 1.25 cylinder. We decided to put an ICL 13.2 mm, and the ICL surgery itself was uneventful. Post-op day 5, she came for a routine checkup and showed that the vaults were very high, and the ASOCT showed that the right eye was 1.29 mm and the left eye was 1.24 mm. So in a high vault, this is one of the problems with the phakic IOLs, is the sizing. So you can get an undersizing or oversizing. With a very high vault, there is a chance of angle closure over a period of time. So you can see this is the right eye 1.29, so 1300 millimeters vault. It is very high, unacceptable. More than 800 generally we do not accept. This is a V4C. You can see the central hole here, and if you look at the left eye, that is 1.24. So what do you do for such a case? So you have to reduce the vault. So either you have to exchange the lens, but to exchange the lens, again we have to order one more lens, get the lens, remove this lens, put in the lens, which is more traumatic. So we tried a new approach. So as all of you all know, the horizontal sulcus to sulcus is shorter than the vertical sulcus to sulcus, which is different from the white to white. The horizontal white to white is bigger than the vertical white to white. But when you look at the sulcus, the horizontal sulcus to sulcus is smaller. So why not rotate this lens and see if the vault reduces? So this is what we did. We just went in. It's very easy to open the incision. It is just like 5 days, and then under topical anesthesia only, put in viscoelastic to form the chamber. And this is a cannula which I have made, which is sandblasted. It's available with Epsilon. You can use that. You can keep injecting the visco as you rotate, and you have to actually pull the lens and rotate it, otherwise you may tear the zonules. So just slightly pull it centrally and then rotate it. And you can't do this for a toric ICL. This was a standard ICL, non-toric, so we did this. So it's a simple procedure, very atraumatic, and then remove the viscoelastic and close the wound. So instead of placing it in a horizontal position, we just rotated it so that it's in the vertical position. So just washed out the viscoelastic and gently hydrated the wound. The same thing was repeated for the other eye. The other eye also, we just opened it and put in intracameral xylocaine, then injected viscoelastic into the antechamber. I like to use sodium hyaluronate because it comes out as a bolus, and you can just irrigate it out. No need to put in your IA handpiece. You can just rotate it into the vertical position and then wash out the viscoelastic. You just wash out the viscoelastic, it comes out as a bolus. You can see the whole thing comes out as a bolus. It's just like 2 seconds. And post-op, you can see from 1300 it reduces to 782, which is acceptable within 800 microns in the right eye. Left eye was 857, which is okay. So this is almost by about 500 microns you can reduce the vault. So this is a very simple trick that you can do if you have a high vault. This is another case. You can see while injecting the lens, you can see that the lens flips. So now when it flips, you see that part of it is on the right side and most of it is upside down. So how do you manage this case? You can put in viscoelastic and gently what I do is I engage the lens there. It's very precarious because if you are not careful, then it can just flip upside down. So here I put in viscoelastic to maintain the chamber. It's very important. Then I put in the cannula. I slowly manipulate the lens, half of it is rotated. Keep putting viscoelastic. And then what you can do in a V4C is the hole is there. The hole gives you some purchase. So I kind of engage the hole and flip it over. So this is a trick. You can engage the hole and flip it over. Now it's flipped over. Otherwise it would have gone upside down. If it goes upside down completely, then it's very difficult. You can't flip it out. So when it's half upside down, what you can do is you can rotate your wrist as you're injecting and see that most of it at least is not completely upside down, and then you can manipulate it intra-op. But there is a chance that you can damage the endothelium. So you have to be quite skilled and use a lot of viscoelastic if you're doing this maneuver. So we were able to get the lens into position, tuck it under the iris and remove the viscoelastic. So we'll go on to another case where it flipped completely, and then I will show you how we managed it. This is a case 3. This is a 2.8 mm incision. The chances of it flipping are more if you're doing a wound assisted. So here you can see that I'm injecting the lens. You should always watch the landmarks as the lens is coming out. Again, here you can see it is kind of half and half, where it is not completely, and then it flips suddenly. So now it is flipped completely. When it's flipped completely and upside down, you can see that now trying to flip it is quite dangerous because it's opened up completely and it may damage the endothelium. So I just resist that. I just extended it to 3.2 from 2.8. Then you can go in with the same loading forceps, grab the optic haptic junction, that's where it is thickest, and then you can just pull out the whole lens. You need not have to extend it too much. And then you can reload the lens. That's reloading the lens. That's the pull through forceps. You'll have to see that all 3 lenses, the paracentral and the central holes, are aligned in the lens. If it's aligned, then it will come out properly. If it's not aligned and it is twisted in the cartridge, then the chances of it opening upside down are more, especially in thinner lenses, lower powers. So now it is opened out properly, and then I complete the surgery by just tucking in the haptics and removing the viscoelastic. This is a cannula which I have made. Like I use a single incision. You can go over and just tuck it. It is sandblasted on the underside, so I put it on my visco syringe so I can inject the viscoelastic to deepen the chamber, at the same time manipulate or tuck in the haptics, and then I just aspirate the viscoelastic. I normally use sodium hyaluronate because it comes out as a bolus. This is another case. You can see the lens is rotated and it has come in horizontally. So I think, okay, we just have to rotate it back. So I mark the 0-180. It's actually supposed to be placed at about 15 degrees or so. So I think this is a patient where I can just rotate it, and because this patient came in after almost 6 months, I think he rubbed his eye or something and he said the vision is blur, and then we found that the lens had rotated into the vertical position. The lens very easily rotates into the vertical position because that is the longest axis in the sulcus. So here I am just ensuring that it is in the correct axis. You can re-rotate it. After re-rotating, you can see that I make sure that I place the lens correctly in the axis. Then I have to remove the viscoelastic. Again, recheck with the Mendes marker. I think it was about 15 degrees, so I placed it at the axis. And I am hydrating. So once I remove the viscoelastic, you can see that I am hydrating. Watch very carefully what happens when I am hydrating this side port. Again, I check the axis is fine. So I'm happy that it's aligned, and then we are done with the surgery and I can finish. Then I just check the IOP. I find that it's little soft, so I think I'm going to form the AC a little more, hydrate a little more. And as I hydrate, you can see what happens. The lens just shifts into the vertical. This in slow motion, you can just watch it. See, it just rotates. So when you're hydrating, again, it's very important that you don't overhydrate. Again, I positioned this lens, but I went back and ordered the next size, because this can happen again whenever the patient presses the eye. In high myopes, the sclera is very compliant, so the sulcus expands and suddenly this lens can rotate. So there's a chance of this happening. So I ordered next size, and then we finally replaced this lens because it rotated again. So these are a few interesting cases. Thank you very much.